بسم الله الرحمن الرحيم. رب اشرح لي صدري ويسر لي أمري واحلل عقدة من لساني يفقه قولي. During this presentation we will deal with postpartum hemorrhage. Postpartum hemorrhage is any blood loss that has the potential to produce hemodynamic instability. Postpartum hemorrhage is the most important single cause of maternal mortality worldwide. It accounts for 34% of maternal deaths in developing countries. Postpartum hemorrhage is the leading cause of maternal mortality in Egypt. In the United States, 8% of these deaths are caused by postpartum hemorrhage. In developed countries, postpartum hemorrhage ranks in the top 3 causes together with embolism and hypertension. In the developing world, 25% of maternal deaths are due to it. According to the Royal College Green Top Guidelines number 52, primary postpartum hemorrhage is the most common form of major obstetric bleeding. Primary postpartum hemorrhage is the loss of 500 milliliters or more from the genital tract within 24 hours after childbirth. Postpartum hemorrhage may be minor or major. Major postpartum hemorrhage can be divided into moderate and severe form. This classification is according to the amount of blood lost as seen in the slide. Secondary postpartum hemorrhage is defined as abnormal or excessive bleeding from the birth canal between 24 hours and 12 weeks postnatally. Other definitions of postpartum hemorrhage include any blood loss exceeding 500 milliliter at vaginal delivery or exceeding 1000 milliliter at cesarean. According to the American College, 10% drop in hematocrit or need for blood transfusion is considered as postpartum hemorrhage. In case of vaginal delivery, any blood loss exceeding 1000 milliliter is considered as severe postpartum hemorrhage. In other words, any amount of blood loss causing hypovolemia or hemorrhagic shock manifested by tachycardia, hypotension, or reduced urine output is considered as postpartum hemorrhage. Risk factors for postpartum hemorrhage include placenta previa and placenta accreta, anticoagulant therapy, coagulopathy, over-distended uterus, grand multiplicity, abnormal labor pattern, chorioamnionitis, large myomas, and previous history of postpartum hemorrhage. All of these risk factors can help in prediction and prevention of postpartum hemorrhage. Postpartum hemorrhage can be prevented by active management of third stage of labor. Active management of third stage of labor can be achieved by administration of uterotonics after childbirth, delayed cord clamping, delivery of the placenta by controlled cord traction, followed by uterine massage. Causes of postpartum hemorrhage can be summarized by the following 4 T's. T for tone, T for tissue, T for trauma, T for thrombin. Uterine overdistension, uterine infection, or any uterine distortion like congenitally malformed uterus may be a cause of uterine atony, which leads to postpartum hemorrhage. Any retained products of conception may be a cause of postpartum hemorrhage. Any genital tract trauma during labor like ruptured uterus or vaginal or cervical laceration may be a cause. Coagulation abnormalities, either hereditary or acquired, may be a cause for postpartum hemorrhage. This figure demonstrates the incidence of the different four causes of postpartum hemorrhage. Uterine atony is responsible for about 70% of cases. Retained tissues responsible for about 10% of cases, and genital tract trauma responsible for slightly less than 20% of cases, and abnormal coagulation is responsible for about 1% of cases. This slide demonstrates the different causes of postpartum hemorrhage and their relative incidence, and how to deal with each of them. Management of postpartum hemorrhage can be achieved by postpartum hemorrhage drill. Postpartum hemorrhage drill is a clear and logical sequence of steps essential in its management. The comprehensive triad of management of postpartum hemorrhage include medical, mechanical, and surgical lines. Hemostasis is an algorithm for management of postpartum hemorrhage. H for help. A. Assess and resuscitate the patient. E. Establish the cause. M. Do uterine massage. O. Oxytocic administration. S. Shift to operative theater. T. Tissue trauma must be excluded and then proceed to tamponade. A. Apply compression sutures. S. Systematic pelvic devascularization. I. Interventional radiology. S. Subtotal or total hysterectomy. First, call for help. Teamwork is needed. Team must include skilled obstetrician, trained anesthetist, clinical hematologist, and supporting staff. Assessment and resuscitation can be achieved by ABC, airway, breathing, assess circulation, secure two wide bore IV lines, take blood sample for blood grouping, cross matching, CBC, liver function test, kidney function test, and coagulogram. Positioning of the patient must be flat. Keep the patient warm. Give oxygen therapy by mask, 10 to 15 liters per minute. Catheterize the patient for emptying the bladder and monitoring urine output. Fluid replacement is done by rapid warmed infusion of fluids. Crystalloids is the fluid of choice until compatible blood is arranged. Each 1 milliliter of blood loss is compensated by 3 milliliter of crystalloid. Total volume of 3.5 liters of clear fluids are given. 2 liters of crystalloids and 1.5 liters of warmed colloid. If hemorrhage is severe and fully cross-matched blood is still unavailable, uncross-matched O negative blood may be given. Other blood substitutes can be used like fresh frozen plasma, platelet concentrate, and cryoprecipitate if fibrinogen level is less than 1 gram per liter. Continuous vital monitoring is essential. Monitor adequacy of fluid replacement by urine output and CVB. Urine output must exceed 0.5 milliliter per kilogram per hour, and CVB must be between 4 and 8 centimeter water. Main therapeutic goals are to maintain hemoglobin above 8 gram per deciliter, platelet count above 75,000 per milliliter, prothrombin time less than 1.5 mean control, activated partial thromboplastin time less than 1.5 mean control, fibrinogen level more than 1 gram per liter. During resuscitation, try to establish the etiology. Which one of the 40s is a cause for postpartum hemorrhage? First, check for tone of the uterus. If the uterus is well contracted, suspect trauma, and do exploration of the cervix and the vagina in the operative theater. This slide demonstrates the distribution of the organizing team during management of a case of massive postpartum hemorrhage. Persons at the patient head must check for airway, check for breathing, administer oxygen, do positioning of the patient flat. Persons at the patient arms must check for pulse and blood pressure, secure 2 IV lines, take blood samples for CBC and cross-matching of blood units, start fluid resuscitation by 2 liters crystalloids, give some drugs like oxytocin, methergine and prostaglandin. Persons on the right side of the patient must do uterine massage, call for help, coordinate with helper 1 at the patient head, coordinate with helper 2 and 3 at the patient arms. If the bladder is full or palpable, empty it by Foley's catheter and you record urine output. If atony persists, apply bimanual compression. Review other causes of postpartum hemorrhage like trauma, retained tissues, or coagulation abnormality. Then move to the surgery early if bleeding persists in spite of the previous measures. This slide contains the ecobolics or uterotonic drugs used for management of uterine atony. These drugs include oxytocin or syncytinone, centometrine, methergine, carbitocin, injectable prostaglandins, and misoprostol. This photo demonstrates how bimanual uterine compression is done. If the uterus is atonic and relaxed, do uterine massage to stimulate uterine contraction. This will help in expelling any retained parts. Then compress both anterior and posterior uterine walls in between hands as shown in figure. This procedure is done under general anesthesia. This photo demonstrates how vaginal exploration is done. Under general anesthesia, the uterine cavity is manually explored for retained parts or uterine rupture or any other vaginal, cervical, or uterine injury. This photo demonstrates how uterine tamponade is done by Bakri balloon. This photo demonstrates how to apply Bakri balloon either vaginally following vaginal delivery or abdominally during cesarean section. When medical management fails, you will start surgical line of management. Surgical management include uterine conserving lines, which need time, or definitive surgical procedure, which is hysterectomy. B-Lynch sutures are the first compression sutures described. It was commonly performed at cesarean section, but can also be done after vaginal delivery. This photo demonstrates how B-Lynch sutures are done. This slide demonstrates how modified B-Lynch technique is done. This photo demonstrates another example for uterine compression sutures called Heyman uterine compression sutures. It's formed of 4 sutures, 2 verticals and 2 horizontal. The 2 vertical sutures are passed from the anterior to the posterior surfaces of the uterus, and the 2 horizontal sutures are horizontal cervico-isthmic sutures. This photo demonstrates another compression suture called multiple block sutures or multiple square sutures. This photo demonstrates another example for compression sutures called global stitch. This figure describes parallel vertical compression sutures for placenta previa during cesarean section. This slide demonstrates stepwise uterine devascularization composed of uterine artery occlusion of tubal branch of ovarian artery, internal iliac artery ligation or hypogastric artery ligation. This slide demonstrates how uterine artery embolization is done under fluoroscopy. This photo describes the imaging before and after uterine artery embolization. Hysterectomy is the final definitive treatment of postpartum hemorrhage. Resort to hysterectomy sooner rather than later. Documentation and recording of the sequence of events during management of postpartum hemorrhage is very important. This slide demonstrates 3 new drugs used in the management of postpartum hemorrhage. These drugs are tranexamic acid, activated factor 7, and carbetocin or oxytocin agonist. Finally, again and again, please don't forget hemostasis algorithm for management of postpartum hemorrhage. Thank you for your attention. All good wishes and goodbye.